Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a pharmacist, and I'm here to bring you quality information regarding medications and health-related topics. And today, I'll be continuing the hypertension topic. We'll be going over thiazide diuretics today. Just like last time, I'll go ahead and start the video with a couple of questions, and at the end of the video, I'll give you the answers. Question number one, a 58-year-old man with newly diagnosed hypertension is started on hydrochlorothiazide 25 milligrams daily. 2 weeks later, the labs show the following results. Which mechanism best explains the patient's hypokalemia? A 72-year-old man with chronic kidney disease and volume overload is admitted for worsening edema despite loop diuretic therapy. Which thiazide class agent is most appropriate to consider as an adjunct? Question 3. A patient on long-term hydrochlorothiazide presents with muscle cramps in the following labs. Oral magnesium supplementation is started, but magnesium levels fail to improve. What is the most appropriate next step? A 60-year-old man with hypertension and gout is started on hydrochlorothiazide. 2 months later, he presents with acute monoarticular arthritis of the first metatarsophalangeal joint. Which mechanism most directly explains this adverse effect? Question 5. A 55-year-old patient with diabetes is started on hydrochlorothiazide. 3 years later, she is diagnosed with type 2 diabetes. Which mechanism best explains thiazide-associated dysglycemia? And the last question, a patient stabilized on dofetilide is prescribed hydrochlorothiazide by an outside provider. What is the primary reason this combination is contraindicated? Let's take a look at how thiazides work. The mechanism of action of a thiazide diuretic is that they inhibit the sodium chloride cotransporter in the distal convoluted tubule. This leads to an increase in urinary excretion of sodium chloride in approximately equal amounts, resulting in an acute reduction of plasma volume. The reduction in plasma volume then triggers a compensatory activation of the RAS system to increase renin release and aldosterone secretion. Aldosterone aids in the reabsorption of sodium in the late distal tubules and collecting ducts via upregulation of epithelial sodium channels and increased activity of the sodium-potassium ATPase. As sodium is being reabsorbed in the late distal tubule and collecting duct, the tubular lumen becomes relatively negatively charged. This electrical gradient promotes the movement of positively charged potassium ions from the cell into the lumen, increasing urinary potassium excretion. The drop in blood pressure is initially due to diuresis. Diuresis causes reductions in plasma volume and stroke volume, which decreases cardiac output and blood pressure. However, after about 6 to 8 weeks of therapy, extracellular fluid and plasma volume return to near pretreatment levels, while peripheral vascular resistance decreases to below baseline. This sustained reduction in peripheral vascular resistance is responsible for the chronic antihypertensive effects of thiazide diuretics. The mechanism why this occurs remains incompletely understood. Examples of thiazide diuretics include hydrochlorothiazide, chlorthalidone, indapamide, and metolazone. A 2025 meta-analysis published in The Lancet found that one standard dose of thiazide or thiazide-like diuretics reduced systolic blood pressure by about 10.8 millimeters of mercury, which is the largest reduction among the major antihypertensive drug classes. For diastolic blood pressure, an average reduction of 4 millimeters of mercury can be expected. Adverse effects include skin photosensitivity, electrolyte imbalances, hyperuricemia, and hypercalcemia. Some of its contraindications include hypersensitivity to sulfonamide-derived drugs, anuria, and in the Canadian labeling, breastfeeding. Some of its warnings include sulfa allergy, patients diagnosed with Addison disease, patients who are diabetic, hypercholesterolemia, parathyroid disease, and severe renal impairment. FDA indications include prevention of calcium nephrolithiasis, nephrogenic diabetes insipidus, volume overloaded patients, and chronic hypertension. Hydrochlorothiazide has been around for a very long time, so the only brand name available is Zircon, which is an oral suspension. Hydrochlorothiazide is available in a capsule, tablet, and oral suspension. The dosing varies depending on the indication, with doses as low as 12.5 milligrams once a day for hypertension. For patients who are being treated for volume overload with hydrochlorothiazide as an adjunct, 200 milligrams total daily dose may be administered. It's not recommended for patients with a creatinine clearance of less than 10, and its diuretic effect is diminished in patients with a creatinine clearance of less than 30. It is used in pediatric patients with a weight-based dosing regimen, depending on the indication. Its drug interactions include administration of photosensitizing medications, dofetilide, lithium, and obinutuzumab. Chlorthalidone has also been around for a long time as well. It was approved in the 1960s, so its original brand name is no longer seen. It has two brand name oral formulations that are available at lower strengths, and I've never seen either one personally. The generic version is available in 25 and 50 milligram tablets. The dosing for chlorthalidone is once a day dosing, and for hypertension, the recommended dose ranges from 12.5 milligrams to 25 milligrams. If being used as an adjunct agent for edema, doses of up to 100 milligrams per day may be used. Its renal and hepatic adjustments resemble those of hydrochlorothiazide. Its drug interactions also align with those of hydrochlorothiazide as well. Metolazone has been around since the 1970s, and I couldn't find any brand name that was available. It's mostly indicated for the treatment of edema. Metolazone's pharmacokinetics are less predictable compared to hydrochlorothiazide and chlorthalidone. It has erratic and slow absorption. It also was not part of the landmark trials which established thiazide diuretics as first-line antihypertensive medications. It does, however, maintain its efficacy in patients with a decreased renal function, unlike the other agents. Even though no dosage adjustment is necessary for patients with an eGFR of less than 30, its dosing frequency may need to be extended to every other day or longer if diuresis is occurring faster than desired. Dapamide is another thiazide diuretic that was approved in the 1980s and also has once-a-day dosing just like chlorthalidone. It has no brand name currently available and is not approved for the use in children. It does demonstrate additional vascular benefits beyond blood pressure reductions. In patients with both hypertension and diabetes, it improved endothelial function, arterial compliance, and longitudinal left ventricular function compared to hydrochlorothiazide. It also has a more favorable metabolic profile with minimal effects on lipids. Thiazide diuretics can be classified either as a thiazide type or thiazide-like. Thiazide type contain a benzothiazidine ring. Hydrochlorothiazide is considered a thiazide type. Thiazide-like diuretics lack this ring. Chlorthalidone, indapamide, and metolazone are considered thiazide-like. Despite their structural distinctions, both classes work at the distal convoluted tubule. Thiazide-like diuretics have a longer half-life and produce greater blood pressure reductions when compared to hydrochlorothiazide. The 2025 AHA-ACC hypertension guidelines just grouped them both into one group, labeled thiazide-type diuretics, for simplicity and to minimize confusion. The guidelines state that in most settings, it's acceptable to choose among these agents for treatment. Besides decreased levels of sodium and potassium, thiazide diuretics also cause hypomagnesemia by increasing urinary magnesium excretion. What I want to point out is that magnesium homeostasis is tightly linked to potassium. Hypokalemia worsens hypomagnesemia. Potassium depletion directly reduces magnesium uptake in the distal convoluted tubule cells by depolarizing the plasma membrane, reducing the electrochemical driving force for magnesium entry through TRPM6 channels. Hypokalemia also impairs the sodium-potassium ATPase, depolarizing the basolateral membrane potential and reducing the sodium-magnesium exchanger, which normally allows magnesium to enter the bloodstream, which creates a bottleneck where magnesium is lost in the urine instead of being reabsorbed. So what does this mean clinically for patients on thiazide diuretics experiencing hypomagnesemia? To correct this electrolyte imbalance, it's essential we correct thiazide-induced hypokalemia. Why is hyperuricemia a side effect of thiazide diuretics? The natriuresis and diuresis caused by thiazide diuretics leads to mild extracellular volume depletion, which triggers a compensatory increase in proximal tubular sodium reabsorption. Sodium is utilized via sodium-coupled transporters to increase intracellular levels of organic anions within proximal tubular cells. These organic anions are then utilized by urate transporter 1, the primary apical urate reabsorptive transporter, which exchanges intracellular organic anions for luminal urate, increasing urate reabsorption and raising serum uric acid levels. Thiazide diuretics also compete with urate for proximal tubular organic anion transporters that are involved in urate secretion, resulting in reduced renal uric acid excretion. Hyperuricemia increases in a dose-dependent manner and persists throughout therapy, increasing the risk for gout flares. Patients taking thiazide diuretics should be advised that it can increase sensitivity to ultraviolet radiation. This can create exaggerated sunburns. Hydrochlorothiazide disrupts the DNA damage response following UV exposure. Thiazide-induced hypercalcemia occurs through enhanced renal proximal tubular calcium reabsorption. These elevations in serum calcium are typically asymptomatic and are self-limiting. Severe hypercalcemia is rare. Sulfonamide antibiotics and thiazide diuretics share a sulfonamide moiety, but true cross-reactivity between these drug classes is rare. Most of the evidence available suggests that routine avoidance of thiazides in patients with a prior sulfonamide antibiotic allergy is not necessary unless there is a history of a severe reaction such as Stevens-Johnson syndrome or drug-induced thrombocytopenia. Sulfonamide antimicrobial agents such as sulfamethoxazole or sulfadiazine possess two critical features absent in thiazide diuretics: an aromatic amine group at the N4 position and a substituted ring at the N1 position. For type 1 IgE-mediated immediate hypersensitivity reactions, the immunologic determinant is the N1 heterocyclic ring, a structure that non-antibiotic sulfonamides, including thiazides, completely lack. Addison's disease is a chronic disorder where the adrenal glands do not produce enough cortisol and aldosterone. Loss of aldosterone leads to decreased sodium reabsorption and volume depletion. If you remember from earlier, when thiazides cause volume depletion, the RAS is activated, creating a rise in aldosterone, but this compensation fails in Addison's disease, so sodium loss continues, exacerbating hyponatremia and hypotension. Thiazide diuretics are associated with new onset diabetes in 3 to 4% more patients compared to other antihypertensive classes over several years of treatment. The mechanism why this occurs seems to involve hypokalemia-mediated impairment of insulin secretion. Hypokalemia impairs insulin secretion primarily by altering the membrane potential of pancreatic beta cells, reducing their excitability and ability to release insulin in response to glucose. However, recent experimental data suggests that thiazides also directly inhibit insulin secretion through a potassium-independent mechanism involving mitochondrial carbonic anhydrase. Despite worsening glucose control, the cardiovascular benefits of thiazides outweigh the metabolic risks in diabetic patients. The precise mechanisms underlying thiazide-induced dyslipidemia are not fully understood. Thiazide-induced insulin resistance may contribute to increased hepatic very low-density lipoprotein synthesis, leading to elevated triglycerides and subsequently increased LDL cholesterol through lipoprotein metabolism. Hydrothiazides, which would be 50 to 100 milligrams of hydrochlorothiazide or equivalent, increases total cholesterol and LDL cholesterol by approximately 5 to 7% and triglycerides by similar amounts during the first year of therapy. These lipid elevating effects appear to be transient. Review of 3 to 5 year diuretic-based clinical trials found that cholesterol levels do not remain elevated long term. Again, the cardiovascular benefits of thiazide therapy outweigh any theoretical risks from modest lipid changes and often do not require intervention at low doses typically used for hypertension management. Let's look at some of the interactions with thiazide diuretics. The manufacturer of the phthalate states it's a contraindication to the use of hydrochlorothiazide due to pharmacokinetic interactions. Hydrochlorothiazide, 50 milligrams, once a day, co-administered with the phthalate, 500 micrograms twice a day for 5 days, increase the phthalate plasma concentrations. Dofetilide exhibits a linear relationship between plasma concentration and QTc interval prolongation. Any increase in dofetilide levels directly increases an arrhythmia risk. Dofetilide is eliminated primarily by renal excretion, with approximately 80% excreted unchanged via both glomerular filtration and active tubular secretion through a cationic transport system. Hydrochlorothiazide appears to interfere with this renal transport mechanism, reducing dofetilide clearance and elevating systemic exposure. The American College of Cardiology, the American Heart Association Heart Rhythm Society guidelines explicitly list concomitant use of hydrochlorothiazide among the contraindications to dofetilide therapy. Thiazide diuretics increase serum lithium concentrations by reducing renal lithium clearance through diuretic-induced sodium loss. Lithium is handled by the kidney similarly to sodium. Sodium depletion triggers a compensatory increase in proximal tubular sodium reabsorption, which simultaneously enhances lithium reabsorption. Lithium has a narrow therapeutic index. Thiazide diuretics increase lithium concentrations by 25 to 40% after initiation of therapy, with the effect typically becoming evident within days to weeks. In lithium-treated patients who require treatment with a thiazide diuretic, a dose reduction of lithium of about 25 to 50% should be anticipated. Obinutuzumab is an FDA-approved prescription intravenous anti-CD20 monoclonal antibody therapy. It is primarily used for untreated chronic lymphocytic leukemia, as well as follicular lymphoma and lupus nephritis. The interaction with obinutuzumab and thiazide diuretics is a pharmacodynamic interaction rather than a pharmacokinetic interaction. The FDA labeling recommends withholding antihypertensive treatments, including thiazide diuretics, for 12 hours prior to, during each obinutuzumab infusion, and for the first hour after administration until blood pressure is stable. Obinutuzumab causes infusion-related reactions in up to 59% of patients, with hypotension being a recognized component of these reactions. Okay, if you've made it this far, then here are the answers to the questions at the beginning of my video. The answer to number 1 was C, enhanced sodium reabsorption in the collecting duct, creating a lumen negative gradient. The answer to number 2 was D, which is metolazone. The answer to number 3 was C, which is correct hypokalemia. The answer to number 4 was C, increased proximal tubular urate reabsorption. The answer to number 5 was B, hypokalemia-induced beta cell dysfunction. And the answer to question number 6 was C, reduced renal tubular secretion of dofetilide. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Also, if you have any comments or any feedback for me, please feel free to comment below. Thank you and have a great day.